Hemothorax, in the case of blunt trauma or penetrating injury, a pneumothorax may also accompany a hemothorax, and we're going to talk about a pneumothorax next. But a hemothorax is an accumulation of blood that occurs in the pleural space. It is this accumulation of blood that is exerting pressure onto the pulmonary structures. When this happens, it causes the alveoli to collapse. And when the alveoli collapse, it decreases the surface area that gas exchange can occur. So, okay, as we critically think this through, hypovolemia is occurring because we've got an accumulation of blood going where it shouldn't be. As the bleeding decreases vascular volume that is circulating, it's accumulating in the pleural space. So the severity of a hemothorax depends on the amount of actual blood loss. A massive hemothorax is considered to be a blood loss of greater than 1,500 milliliters. This blood loss can occur from trauma to the heart, to the great vessels, or to the intercostal arteries. Your assessment findings, when you assess this client, should correlate with the amount of blood loss. So, a small hemothorax may be present, and your patient may show no signs or symptoms. A large hemothorax, if it is present, it's likely your patient will display some respiratory distress, some diminished breath sounds, a dull sound when the affected side is percussed, and there will be evident blood in the pleural space when an x-ray is taken. A pneumothorax is an abnormal presence of air between the lung and the pleural cavity, and this is also sometimes known as a collapsed lung. Another way to say this is that the abnormal presence of positive atmospheric pressure, or air, between the lung and the pleural cavity results in a collapsed lung. Normally the pressure in the pleural cavity is negative, and this negative pressure is needed to keep the lung inflated. When either the parietal or the visceral pleura is breached, the air then enters into the pleural cavity, and then it increases the intrathoracic pressure, which in turn actually causes a portion of the client's lung to collapse. There are 3 classifications of a pneumothorax. There's a spontaneous, which usually is non-life-threatening. It can result from a rupture of a bleb or a blister that is on the surface of the visceral pleura. It can also occur from your chronic obstructive pulmonary disease patient. A traumatic pneumothorax usually occurs with a blunt trauma to the chest. You can have either an open or a closed traumatic pneumothorax. An open pneumothorax is when outside air enters into the pleural space. A closed pneumothorax occurs when air from the lung enters the pleural space. So both closed traumatic injury and a tension pneumothorax injury are considered to be life-threatening emergencies that require early detection and treatment. Your tension pneumothorax that I just mentioned occurs when air leaks into the lung or chest wall and leads to that collapsed lung. Air enters the pleural space with each time the patient breathes in or with each inspiration, but the air doesn't exit during expiration. So what does a panicked patient do? They start breathing faster and deeper, but this air is not being exhaled, it's being trapped. and this presses blood vessels and decreases the venous return. The result is reduced cardiac filling and decreased cardiac output. It can also occur from complications of mechanical ventilation with PEEP. Remember we said PEEP was the positive end expiratory pressure in the lung. And the insertion of central venous catheters may also cause a tension pneumothorax. Your assessment of the client with pneumothorax is likely going to reveal decreased breath sounds on the effective side, hyperresonance on percussion. Now with the hemo, it was a little bit different from hyperresonance. It was a dull sound because a hemo is over fluid filled, but your hyperresonance on percussion with a pneumothorax is over an air field. You're also going to see a prominence of the affected side. It's a little bit larger. Tracheal deviation. This is important to note because your tracheal deviation is going to be away from the affected side with a closed pneumothorax, and it's going to deviate toward the affected side with an open pneumothorax. You're also going to assess your patient to have tachypnea, respiratory distress, cyanosis, pleuritic pain, and possibly sub-Q emphysema. Now this is an air pocket that gets into the subcutaneous tissue just under the skin. When it is palpated or pressed, it sounds like Rice Krispies popping. It's usually painless for your patient, but if it does become an issue, these little air pockets can be drained with a needle. Also, your patient may exhibit distended neck veins. An intervention for your pneumothorax is to access the patient's lung cavity, pleural space with a large bore needle, and then to put in a chest tube. The initial treatment of your tension pneumothorax is the insertion of that large bore needle at the second intercostal space, at the mid-clavicular line, or can be done at the mid-axillary line, on the affected side, followed by the insertion of that chest tube that is going to be connected to a water-sealed chest tube drainage system. So you can see that the image on your left is mid-clavicular. The image on the top is also mid-clavicular, second intercostal space, but on the pediatric patient, it is mid-axillary on the affected side. As a nurse, your key role for caring for the client with a hemo or a pneumothorax is assessing that chest drainage system and monitoring your patient for any changes. Sometimes they're subtle, any worsening of the patient's condition. Your chest tubes are going to be inserted for one of two reasons. We've talked about both of them. It's going to be either to drain the chest cavity or to reinflate the lung. So draining would be with a hemo, reinflation would be with a pneumo. Maybe one or two or a 3-bottle chest tube drainage system setup, which I have given you on the right of the slide. Used to be glass bottles used and have a glass bottle system, and these have been replaced by the disposable chamber system that you see on the left. The first chamber in the system does not, I'm sorry, not the first chamber, but the one chamber system. The one chamber system does not allow for suction control, and it can't handle large amounts of drainage. So the water seal and drainage bottle in example A would be a one chamber setup. In a 2-chamber setup, The first chamber, again, collects the drainage, and the second chamber controls the amount of suction applied. So that's going to be your image example B, the water seal and drainage bottle, then connected to the suction bottle control. The traditional water seal, or a 3-chamber setup, the first chamber collects the drainage. The second will then act as a water seal, and the third chamber will control the amount of suction applied. Now you'll notice the image on the right with the bottles is exactly opposite to the way the Pleurovac is set up. The Pleurovac chambers are set up for suction, then the water seal, and then the drainage. But, I mean, either way is the same. It's going to promote the same outcome. On your Pleurovac, which is likely what you will see in the hospital, the blue chamber, beginning on the left, is the water-filled suction chamber. The red is the water seal chamber, and the white is the drainage collection chamber. Went too far. The management of chest tube drainage systems. The collection chamber is going to act as a reservoir for fluid that's going to be draining from the chest tube. There is a one-way valve in the water seal chamber that is going to prevent air from moving back into the chest when your client inhales. Now, titling is going to occur with inhalation and expiration, and it is going to increase the water level. It occurs when the patient breathes in and then returns when the patient breathes out. So you'll see that fluctuation of water movement that should correlate with your patient's breathing, and this is totally normal. It's called titling. The suction control chamber regulates the amount of negative pressure that is applied to the chest cavity. The amount of suction applied is going to be determined by the amount of water in the suction chamber. The amount of suction is generally set at 20 centimeters of water. You want to monitor the color, the amount, and the consistency of the drainage. Note and look for those fluctuations that I just talked about in the water seal chamber. Those fluctuations will stop when the tubing is obstructed. Possibly there is a dependent loop hanging, or if the suction isn't working at all, you will see that the titling or fluctuations in the water seal chamber will stop. Assess the suction control chamber for any bubbling. Constant bubbling in the water seal chamber can indicate that there is an air leak. Assess your external tubing for any kind of air leak that you can find. If that constant bubbling exists in the water seal chamber and you determine that there is no external leak in the tubing, your physician should be notified immediately, because this air leak is worsening of the patient's condition. Ensure that the drainage tubing doesn't interfere with the client movement. If the tube becomes disconnected from the client, the nurse must cover the insertion site immediately with a petroleum gauze, monitor for the development of a pneumothorax, and notify the physician immediately. Gather the equipment for reinsertion of the chest tube. Whenever transporting this client, the drainage system should always be kept below the chest level, and if the tubing becomes disconnected from the collection device, the end that pulls out of the collection device is then considered contaminated. So what we're going to do is cut off that contaminated tubing and insert a sterile connector and reattach that tubing to the drainage system. We never clamp the chest tube during transportation. When you are assisting with chest tube removal, you're going to instruct the client to perform a Valsalva maneuver. While this patient is bearing down, the tube is clamped and quickly removed by the physician. While the physician is doing this, the nurse simultaneously applies a small petroleum gauze covered quickly by a 4x4 gauze pad that is then completely covered and sealed with non-porous tape. Monitor this patient very closely for signs of reoccurring pneumothorax. So according to what you just learned, what needs to be kept at the bedside at all times for this client who has a chest tube? This is another polling question that you'll type in during class. Intubation and ventilation. As we already discussed, specific to the client with ARDS, this client's going to have severe problems with maintaining adequate gas exchange. So your client with ARDS is being given 100% O2, but their SaO2 level is still less than 90%. Arterial CO2 is building up because of that poor gas exchange. So let's say now that their CO2 is greater than 50, their pH is also falling. It's below 7.35 now. Your patient is acidic and will require intubation and ventilation because your patient is hypoxic and we're not able to ventilate them. They're becoming respiratory acidotic. An endotracheal tube is a long polyvinyl chloride tube that is going to be passed through the nose if it is a facial trauma, and we have no other choice, but through the mouth is usually the preferred and quickest form of intubation. We're going to pass that tube through the mouth or nose into the trachea, not into the esophagus. You can see on the image where the esophagus is and how easy it would be for that tube to go straight down and into the esophagus, which is not what we want. We want the tubing tip of the catheter to pass into the trachea. With proper placement, the tip of the tube will lie about 2 centimeters above the carina. The carina is the ridge that separates the opening of the right and left main stem bronchi just at their junction with the trachea. And here are some images of the carina. So you can see there are the left and right, and the carina is just that portion of cartilage that separates it. So we want the tubing to set just about 2 centimeters above that junction. ET tube management, indications for intubation should be in your text, figure 34.3. The parts of the ET tube, you'll have the shaft, the cuff, the pilot balloon, and the universal adapter, as seen here. Explain the procedure to your client as clearly as possible. Your job during intubation, you may be the transcriptionist, you may be checking vital signs, assisting the respiratory therapist, the physician, the pharmacy, etc. You're always going to be assessing your client for hypoxemia, dysrhythmias, and aspiration, and be prepared to push drugs as recommended by the physician during this procedure. You're also going to be counting, ensuring that intubation attempts do not exceed 30 seconds. Preferably, they are less than 15 seconds with each attempt. After each attempt if more than one is required. We're going to want to provide that client with O2 by mask or manual resuscitation bag to prevent worsening hypoxia and cardiac arrest. We're going to suction PRN, and basic life support measures are going to be crucial to this client's survival. After the client is intubated, you must verify tube placement. If breath sounds and chest wall movement are absent on the left side, the tube might have been inserted into the right mainstem bronchus, and the tube should be repositioned without requiring a complete repeat of the entire process. Now, ideally, this tube has been inserted too far and can be pulled back a little to reposition, but it is not considered that the sterility has been compromised. Now, if it is inserted into the esophagus, it's going to be no longer considered in a sterile environment, and the tube will need to be withdrawn, and a new attempt with new equipment will be required. So, as we critically think this through, where does the esophagus end? In the stomach. So if the tip of the tube is in the esophagus, when you auscultate over the stomach, you will hear loud breath sounds that you should not be hearing if it is in the esophagus. At any rate, after the patient is properly intubated, and we have verified the tube placement with chest x-ray, a chest x-ray must be done to verify the placement. We're going to then stabilize the endotracheal tube at the mouth or nose, wherever it's inserted, marking the tube at the level where it touches the either nares or the incisor, because we want to know that that marking is always in the same place. That'll help us know if it has been, accidentally pushed too far in past where we verified tube placement, or if it's been pulled out after we verified tube placement. So we want to mark that tubing. Usually it's with a piece of tape. We usually do not write on the tubing. And then secure it. You can refer to chart 34-9. At any rate, with endotracheal tube intubation, we must first verify and then stabilize this tube placement.
Chances are you don't think of insurance claims, as in the 900 million health insurance claims we...
This presentation will cover tube positioning and repositioning, oral care, and cuff pressure checking. This is important for the following reasons. Number one, verification that the endotracheal tube is secure and in the proper position is one of the most important duties of the critical care therapist. So do this first. It's no exaggeration to say that an improperly positioned ET tube can be deadly. To prevent pressure ulcers, repositioning of the endotracheal tube to the opposite side of the mouth will be performed once a day. Good oral care is an important step in prevention of ventilator-associated pneumonia. Here's what the kits look like. Proper maintenance of cuff pressure is important to prevent the dreadful complications such as tracheal malacia. And now for the sequencing of those events. With the first ventilator check, you'll note the position of the endotracheal tube and record that centimeter mark at on the ventilator sheet. Before the next ventilator check, we will verify that the position of the endotracheal tube is correct on the chest x-ray. That's another presentation on how to read the chest x-ray. Also, with the second ventilator check, we'll start performing our oral care. Before we do our cuff pressure check and our changing or repositioning of the ET tube, we'll need to do good pharyngeal care by using the short 14 French catheter, oral care. We'll also reposition our tube with this vent check, and finally we'll do our cup pressure check. For all subsequent checks that we'll do Q2 hour, we'll perform oral care. Note that the nurses do perform the first oral care with teeth brushing. Okay, I'm going to go over oral care. We use a kit that looks something like this, and inside this kit there is a liquid here. Now you might notice that on the Sage kits there's two different color liquids. Now the first one in the kit is a toothbrush. The nurses will use that with the first vent check in the morning. They'll use the one with the toothbrush. We also have this one with the blue label on it. That liquid contains hydrogen peroxide and baking soda. And we'll alternate that with the one with the other alternating color label, and that has just like a mouthwash type of solution. Also, there are two swabs in here. One of the swabs has holes and can attach to suction, and there's some mouth moisturizer, and so we're going to use all these things. But we're going to start by opening the liquid in this little pouch right here, and you do that just like this. You squeeze it and pop. You hear that? And you can not only hear it, but you can see the liquid that's been released down in the bottom. And now I'm ready to open it up. I'll be sure to saturate my brush with the liquid, the blue liquid, and take it out. Now I have a swab, and the tip has been saturated with, in this case, the solution that I'm using is the peroxide. I'll take my Yonker device here, and I can simply, this is a Yonker by the way, a sleeved Yonker. By the way, we use these sleeved Yonkers. I recommend that if you run across a Yonker that's not sleeved, throw it away. Use these. But this can be disconnected, leaving just the blue handle in place. Blue handle has an on-off switch that applies suction. You can see I have it hooked up to suction. Now, connect my swab to there, and now I'm ready to go see my patient. And I'm going to swab this liquid around, and I'm going to turn my suction on and get it back out. Okay, here's my intubated patient, and I have this particular patient intubated, and I have a device holding the tube in place called a Hollister. And one thing I like about the Hollister, although it's not probably suitable for everyone, there's no real substitute for good old-fashioned tape sometimes, but this Hollister allows you to pinch and move the position of the tube. Before I do that, though, I'm going to use my swab, and I'm going to try to run this around in the mouth. I'm going to try to coat the tongue. I'm going to try to get the roof of the mouth around the teeth, although I'm not brushing the teeth, and the gums. And to cover that, and then right behind it, I can turn my suction on and suction the liquid right back out. So this not only cleans the mouth, there's no rinse cycle, so to speak, with this. You just use the liquid. And it does foam up a little bit. The peroxide solution does. The mouthwash one does not, that we alternate with. After this has been done, I'm going to remove my, I'm going to get another device. This device is a short 14 French catheter. Hey there? It's, what would you say, is about 9 inches long. And this catheter is made to clean out the oropharynx. I can follow along the side of the tube real carefully. Now, of course, patients don't like this at all. I can follow along the side of the tube, turn on my suction, and I can get that area, the laryngopharynx area, which really is kind of impossible to get with the Yonker device by itself. So because of this flexibility and because it can go deeper, it has the ability. And I should do a deep maneuver, a maneuver to get the pharynx if I'm going to do cup pressure, if I'm going to change my tube position. Anytime you do procedures like that, it's important to be real careful and get that area of the larynx, because this alone, the Yonker by itself, is too rigid to really get deep enough. This time is my second vent check around there. I've already checked my x-ray and I see that my tube position's good. So now I'm going to clean my mouth out. I've done oral care on this side. I'm going to move my tube to the other side of the mouth now. That's the great thing about this Hollister. You just unlock it and move it. And now I can do repeat the oral care and repeat the oral care on this side. Okay? Now after that's done, the next step is to go back to my kit. I'm going to take out the other swab and I'm going to get this mouth moisturizer. I noticed the kit I have happened to have 2 brushes in there. I didn't realize this particular kit had 2 brushes. The mouth moisturizer will be coated. Of course, I'd have gloves on, but I'd coat my swab good with mouth moisturizer. The purpose of this is to coat all inside surfaces of the mouth. So after you've done oral care, and in this case I've done oral care, I've done a deep cleaning of the laryngopharynx with my catheter, and I've changed my cuff position. Now I'm going to follow along with my mouth moisturizer, and I'm going to coat all the surfaces on the inside of the mouth with this mouth moisturizer. Finally, after that's done, I can do my minimal leak or cuff pressure check.
The patient with a tracheostomy tube has many care needs. Most important is the maintenance of airway patency. Other needs are preventing infection of either the airway or the stoma, providing some form of effective communication, and providing emotional support. This program will focus on the essentials of direct airway care, including cleaning and changing the inner cannula, caring for the stoma, changing the tracheostomy tube, and maintaining adequate cuff pressure. The patient with a tracheostomy has a surgically created opening through the neck into the trachea or windpipe, usually at the level of the second or third tracheal ring. The tracheostomy tube is placed through this opening directly into the trachea. When a tracheostomy tube is inserted, the upper airway system is bypassed, as are the functions of the upper airway system. These include warming, humidifying, and filtering inspired air. Mucus clearance is performed through the tracheostomy. In addition, the trachea is compromised by the surgical incision and the tracheostomy tube. The presence of the tracheostomy tube and a surgical incision can predispose the patient to respiratory tract and wound infections. Therefore, you should perform effective hand hygiene before and after providing patient care. Observe standard precautions to avoid contact with blood or potentially infected body fluids. Protective equipment such as gloves, gowns, masks, and protective eyewear should be used when there is a risk of bleeding or when secretions are present and there is an effective cough. Performing tracheostomy care requires the use of aseptic technique. Cleaning the inner cannula is generally performed every 8 hours. The inner cannula may be changed every 24 to 48 hours according to hospital policy. However, more frequent care may be necessary depending on the characteristics of the patient's secretions and/or the size of the tracheostomy tube. In most cases, the inner cannula is disposable. It is simply removed, discarded, and replaced with a new inner cannula. In other instances, the inner cannula may need to be removed and cleaned. Follow your institution's policies and the orders of the physician. Before you begin, inform the patient about the procedure. Gaining her cooperation will enhance the effectiveness of the procedure. In case of emergency, be sure a handheld resuscitation bag with mask is near the patient when providing any kind of tracheostomy care. Prior to cleaning or changing the inner cannula, decontaminate your hands and don appropriate personal protective equipment. Because tracheostomy care procedures may stimulate the cough reflex, personal protective equipment typically includes eye protection, a face mask, and gloves.